Welcome to Gold Coast Insider, where we bring you business insights, stories, opportunities, and forecasts from movers and shakers across the Gold Coast. I'm your host, Estella Rodiguero. I'm CEO of Regional Development Australia Gold Coast. Today on Gold Coast Insider, we're diving deep into one of the most exciting frontiers in medical science, the fight to restore function and mobility for people living with spinal cord injuries. Our guest is Professor James St John, head of Clem Jones Centre for Neurobiology and Stem Cell Research at Griffith University. A leading translational neuroscientist, James has spent decades at the cutting edge of neuroregeneration, and now he's on the cusp of a world-first clinical trial that could change lives around the globe. From early studies in agricultural science to pioneering a revolutionary therapy called olfactory ensheathing cells, special cells from the nose, James's journey is one of bold ideas, scientific rigour, and unwavering commitment to hope and healing. So how do you go from the paddocks of Victoria to leading one of the most promising spinal cord injury repair programs in the world? Let's find out. Welcome, James, and thank you for coming on our podcast.
Thank you.
So, can you take us back to the beginning? What first sparked your interest in science, and how did you find your way into neuroscience from your agricultural roots?
Yeah, well, when I was a teenager, my curiosity was what drove me. I liked doing the sciences at school, but I had no idea what science really meant. I just wanted to learn about the world. And my parents were both in the medical field. My dad was a medical doctor. My mum had been a nurse. And so I understood about applying science for healthcare. But beyond that, I really didn't know what science was. So when I left school, I wanted to do science. But again, a science degree often when I was younger was one more of a specific field you had to go into to choose one. I had no idea. So I chose agricultural science because it was so broad. It did everything. It did plants, it did animals, it did soil, environment. And so I could learn everything. And it was also business. So I learned how science is a business from that early time. And I really enjoyed it.
So, you've studied everything, as you said, from international development to molecular biology. How have these diverse disciplines shaped your approach to research?
So my real aim when I was younger was to be an agricultural scientist and to go out into the world, to leave Australia and to apply agricultural science, particularly in developing countries where there's a huge need for improving agricultural practices. Unfortunately, I haven't left Australia yet for work. I'm still waiting for that opportunity because, well, for good reasons. Australia is a fantastic place to do research. And at the end of my PhD, which was in agricultural science, looking at carbohydrate metabolism in pasture grasses, of all things, it was offered a job to work on carbohydrates as guidance factors for neurons, nerve cells in the olfactory sense of smell system. And life gets in the way of big plans. And I decided to jump ship to go from agriculture into neuroscience. I honestly had no idea what a brain was and how it functioned. But what I did know was how to do science and how to apply things. And because I didn't have that dogma of this is how things work in the brain, I came in with some crazy ideas. And some of those have worked. And I think that's an advantage, is to have a different approach to things.
Yeah. And you've mentioned, and I've mentioned, the olfactory system. What drew you specifically to the olfactory system, and how did you first identify its potential of nerve regeneration?
So the olfactory system is the sense of smell.
Oh,
And when we breathe in, we breathe in air, and then the nerve cells that are in our nose detect those odors and they send the signals up into the brain. But it's the oldest sense in a mammalian system. Detecting chemicals in the environment is what first did in evolution. way before there was vision and touch and that sort of thing, hearing. So it's an ancient system, and it's quite different to the other nerves in the human body. And one reason is because those nerve cells are directly exposed to the environment. And when we breathe in, we're breathing in not just the odors, but also air that's full of bacteria and toxic chemicals. And those nerve cells are directly exposed to those, and some of those can die. In fact, every day, about 1 to 3% of the nerve cells that detect the odors die. But they're replaced by stem cells that give rise to new nerve cells that grow from the nose up into the brain every single day. If it didn't happen, you'd lose your sense of smell within about a month or so. But because it's a region that of the nervous system that regenerates every day as part of its normal function, people thought, well, how can we apply that to other parts of the nervous system? And as an example of the regeneration of the sense of smell, we know that some people, when they have a bad cold or COVID, can lose their sense of smell, at least temporarily, but it will come back in most cases, in the vast majority of cases. Some people might have terrible damage. It doesn't come back very well over time, but usually it does come back. So we know it regenerates. We just don't think about it because it happens all the time. Other nerve injuries, like if you have a cut on a peripheral nerve, you can lose function. It's pretty obvious when you have that. But that happens very rarely. Most people don't get nerve injuries. So by understanding the olfactory regeneration processes, we can apply that to repairing other regions of the nervous system, which is where we ended up going for spinal cord injury. We don't do things simple here. We go for the most difficult thing to start with. To repair spinal cord injuries is massively complex, but we think we can do it.
And you're right. Let's talk a bit more about that spinal cord injury repair therapy, which is the groundbreaking use of the olfactory and sheathing cells. Can you explain how the olfactory nerve bridge works in layman terms and how it interacts with the injured spinal tissue?
Yeah. So the cells that we use for the transplantation therapy are olfactory and sheathing cells. Again, olfactory is a sense of smell, and sheathing means they wrap up and sheathe. And so their job in the olfactory nerve is to wrap up and protect the nerve cells as they migrate from or project from the nose up into the brain. They guide the nerve cells to their targets. They secrete growth factors that support their growth, and they also insulate them. We can think of them like the insulation around a bunch of electrical wires.
Okay.
The communication goes through the wires, which are the nerve cells, but we have to insulate them to protect them and keep them from short-circuiting and guide them to their targets too. So in the olfactory system, they have very important roles, not just for protecting the nerve cells, but also every day, those 1 to 3% of nerve cells die. They have to be removed, cleaned up and taken away. And those olfactory and sheathing cells do that job. In other parts of the nervous system, there are specialized cells called macrophages or microglia that come in and do that job. But in the olfactory system, it's the olfactory sheathing cells do it. In fact, they even secrete molecules that prevent those immune cells coming in. And when you think about it, it's logical. If you're always having a turnover of nerve cells in your nose, you don't want those immune cells coming in because they cause inflammation. And you constantly have an inflamed nose, which wouldn't work. So we think because of their evolution, their role in constantly turning over, these cells have very special properties. If we then put them into the spinal cord, they can help remove all the dead cells. They can guide the nerve cells to their target by secreting these growth factors. They can provide a physical surface over which the nerve cells can grow across that injury site. And they can stop those immune cells coming in and causing that inflammation. That inflammation itself can also cause a lot of damage. So these cells have multiple properties, which is very useful for what we call, it's a living drug. A living drug has all these properties. Other therapies, such as a drug, a chemical, would have a single target. That means you got one chance of success. If it doesn't work, then you're going to have to put in something else as well. Because it's a living drug, these cells have so many properties that are useful at different times of the injury. We are very hopeful that they can be used to repair spinal cord injury.
Wow. Sounds so interesting. It sounds intricate.
It is.
And my mind's going, how do you start at scratch and work all the way up to getting to these
Mm.
clinical trials? And I guess that then begs the question, what challenges did you face in developing a therapy that could move to human trials? Because the one thing is going through all the research and study. The next one, the next big hurdle is going into those clinical trials, but it must also be very exciting.
Yeah. So it absolutely very exciting. It's nerve-wracking too. We want to make it right. But the whole basis of what we do is embedded in discovery research.
Yeah.
And it's very important for our community to understand. Discovery research gives us the foundations for understanding what's going on. So I spent the first, oh my gosh, how old am I? The first 20 years of my career doing discovery research. First of all, looking at how the nerve cells grow. And I've specialized in the olfactory system, the sense of smell, how that develops. And you wonder, well, why would you waste your time discovering how the sense of smell grows? And as it fact comes to light, yeah, there are so many reasons we need to focus on our sense of smell. It's been ignored because as humans, we don't pay much attention to the sense of smell. It's just there. It's not like vision or hearing, which is so critical to our daily lives. Um, Discovery research for me at the start was looking at how the nerve cells are guided to the target. And then early or mid 1990s, that's what everyone was looking at. They're thinking, to repair the nervous system, you have to get the nerve cells to go from A to B. You have to get them to make the right connection. And there was a lot of research out there showing how you can guide the nerve cells with growth factors and you can get them to, to find one target or to repel from another target. And over time, I realized that that wasn't enough. And this is where I came in with my untrained, non-neuroscience approaches. I started doing live cell imaging. And I was at the very early times when we could actually do live cell imaging. I mean, I'm so old that when we first started doing microscopy, we had to have actual film in a camera on top of the microscope.
That was
the digital,
ages ago. Yeah.
in the digital, so you couldn't do live cell imaging in those times.
Mm.
And then some brilliant people thought of the idea of having a digital camera, which made it possible then to take multiple images, put them into a movie, and you can see cells moving. And I was one of the very first to do this. And again, I was so out there with my approaches. I remember taking an Olympus microscope and taking different components of it so I could actually image what I wanted to see, and got brilliant images of a nerve cell and the end of the nerve cell within a spinal cord of a fish. There's a little embryonic fish, so I could see through it quite clearly. Um, and I could get this beautiful image of a growth cone moving. And my boss came in at that time and said, "Oh, wow, that's a really good time lapse." He thought I'd sped it up. And I said, "No, this is not time lapse. It was actually real time. And you could see the little ends of it were moving sort of like this fast."
Wow.
Yeah.
Wow.
And I realized at that point, he said, no, I don't move that fast. Everyone shows they're much slower. I said, well, we're the first to do this. I didn't know how fast they should move. So I was capturing it every 2 seconds. Other people were capturing it every couple of minutes because they
Mm.
thought it's slow. And in that moment, it's like a light bulb moment for me. It was, wow, the nervous system moves really quick. Here I was imaging just one nerve cell end. And in our spinal cord, there are millions of them. And after injury, there are millions doing the same thing. But critically, what we weren't seeing were all the other cells around this cell, this nerve cell. And in that moment, I realized that if we want to get the nerve cells to regenerate and repair, we have to get the other cells around them to do their job. And then
Right.
I switched from being a person who focuses on the nerve cells to a person who's focused on the supporting cells, the olfactory and sheathing cells, in our case, of the olfactory nervous system. And then we found out that to get a olfactory nerve cell to go from A to B, you actually have to get the olfactory and sheathing cell to go from A to B, and the nerve cell will follow.
Right.
And wow, for me, it was like, well, now we can repair the spinal cord. All we need to do is put in the cells that will do the pathfinding, that will grow across that injury site, and we make it such a nice environment that the nerve cells that are in the spinal cord and want to regenerate, they'll then just go across that injury site. They'll be able to repair themselves. We don't have to over-engineer it. We don't have to overthink it. We just have to give the cells the environment that they need to do it properly.
So the
That's
right,
our approach.
the right environment for an easy pathway for the cells.
And again, I bring my agriculture. Agriculture is about a holistic approach to the environment.
It is.
And you got to do it in a way that's sustainable and environmentally suitable. That's the same approach with me. While we have all these clever tools where we can do genetic alterations to the cells, we can put in to the cell to change expression of one gene or to reduce the expression of another one. The more you change in a cell, if you change one aspect of a cell, you're going to be changing another aspect of it holistically. You can't just keep on increasing output without changing something else. So from the holistic point of view, our approach to research is to not alter the cells genetically, not put in artificial materials, because that's going to be making the cells do things that they don't normally do. Then we go off into risk.
Yeah.
Risk is very important in medical treatments, is that we have to make sure that we reduce the risk. So the more we change things into could be into a better way, but also risk that we might be put them into unknown side effects as well. So our approach is to give the cells what they need, and they know what to do. We just have to give them the right environment and it's minimal manipulation.
So is that the method difference that you and your team are using as opposed to previous clinical attempts?
Yes, it is in many ways. But we'll go back to the other treatments. So olfactory and sheathing cells have been used before in clinical trials for spinal cord injury, but with limited success. And I went to a talk in about 2017, I think it was, by Australia's chief scientist at the time, Alan Finkel. And he said that innovation is not creating an idea, but it's delivering a product to market and then working backwards from there. And so at that point, I thought to myself, well, in 20 years' time, what would a therapy have in the clinic that we don't have now? What are the therapies that have been tested? What are they missing? And so we looked into the future and we thought, well, a product is going to be something that the surgeons can easily implant quite quickly with low risk to the patient in terms of the surgical approach. Because we know the longer the surgery, the more risk there are. It's going to be a product in which the cells are going to be put into the site where they need it, and most cells survive. And also that there'll be high purity cells that are going to do their job. The previous trials, they took cells, they grew them in a dish, which is a weird flat environment. Cells don't grow flat normally in the body. And then they put them in a liquid suspension. So every single cell was floating by itself. And then they did micro injections into the spinal cord.
Right.
But they can't inject into the cavity because there's a hole there. So they injected the cells into the healthy spinal cord around, above and below the injury site. So each of those micro injections is causing micro damage too. That's not going to be so good. Because of the limited rate of injection, the whole procedure takes hours, about 4 hours or so, to do 240 micro injections.
Wow.
There's risk there too. And with that sort of approach, the vast majority of the cells will be washed away and die within a couple of days. And each individual cell has to fight for its own survival in this foreign environment. So we thought, well, we need a whole different approach. What we did was we created these nerve bridges, which allows the cells to grow together, form stable connections with each other before we transplant them. So it ends up looking like a little worm.
Yeah.
The surgeons can pick it up with the forceps and place it directly into the injury site where the cells are needed. The cells are supporting each other, communicating with each other, coordinating their responses. And then from there, they can migrate out into the spinal cord around, above and below the injury site to form a bridge, and then the nerve cells can go across. With this approach, the surgery is quick,
Yep.
less risk for the patient. The cells are stable, form connections with each other. They're put into the right place. There's much better cell survival and a much better environment for them. So logically, we should get better outcomes.
Sounds very exciting. But what role does long-term intensive rehabilitation going to play in the therapy's success?
Yeah. So that's a great question, because while the science behind it is pretty complicated, complex, and it's taken us years to get to this point. I mean, when we look back, as with any invention, it's obvious, but to get to this obvious point has been years in the making. The transplantation and the cells, from a patient point of view, that's the easy bit. The hard bit.
Can I ask you quickly, how many? So there was about 260 micro. How many with the cells that you're doing?
Yes. So the other benefit with our cells too is that because we have them in a nerve bridge without all the liquid, we can put more cells in too. So typically, you might have a maximum of about 20 million cells put into a spinal cord, but we can go up to about 60 million. And it's still got room for more if we want to, but for this trial, we're limiting it to 60 million.
Okay.
And so I've forgotten what your question was.
How many, like you were saying, there was about 200 micro injections up above and below the injury. Yours goes straight into the injury.
Yeah. So with 60 million cells, we can make about 12 nerve bridges, about 1 centimeter long.
Oh,
and the benefit of that, the surgeons can then place them where they think, because the injury site in a spinal cord can be quite big. It ends up being about 3 or 4 centimeters long in some people. And so they can put in several nerve bridges like in a row or beside each other, or maybe if a person's got particular deficits for maybe one side of the body versus the other, they can target one particular region. So that allows the surgeons to sort of personalize it to each injury site.
Okay.
So that has also another great benefit, we think. And the whole procedure, we think, of actually putting them into the patient is probably only a few minutes, and they just glued in place with surgical glue that's already been used in the clinic. So it's an easy procedure. No sutures are needed, nothing like that.
You're kidding.
Yeah.
So, like, spinal injury affects over, I think, something like 20,000 Australians and millions globally, doesn't it?
Yeah. It's terrible. The terrible thing about spinal cord injury is it happens to perfectly healthy people just doing normal activities. You have a car accident, you have a sporting accident, you fall off a bicycle, or you get in a great surf in the Gold Coast. You might hit a sandbank or something, come off your surfboard, hit a sandbank. And because males are bigger and riskier and stupider, I don't know.
I wouldn't
They
say
have more injuries. About 80% of spinal cord injuries are males, but 20% are females too. And there's nothing that can be done when someone has a spinal cord injury. The best the clinicians can hope for at this point is that they can decompress the injury site and then stabilize it with some metal work, and then sort of cross their fingers and hope that there'll be some natural recovery. And some people, there can be natural recovery, but for many people, it can lead to permanent loss of injury. So in Australia, there's about one person every day has a spinal cord injury. And it's devastating. It's devastating not just for them, it's for their families, it's for their whole support networks, their careers. High level injury, everything below the injury site can have loss of function. For some people, it can be complete loss of function. Others can be partial. And you lose the ability to move, the feel, and the control bowel, bladder, and sexual function. So it's devastating.
It is.
For someone with a high-level injury, they might have to be on ventilation support. They can't breathe on their own. But someone with a slightly lower-level injury, they might be able to move their thumbs, but can't move the index finger. So they can't pick up a fork, or they can't do a button or things like that. But number one is the bowel and bladder loss of control, because that is the time it takes for people to be able to look after that.
Mm.
Or when they go out in a social environment, is to be thinking about, oh my gosh, what am I going to do?
Yeah.
It means that people are often,
Mm.
they don't come out of their homes because it's just too difficult for them. So we really need a therapy. There's nothing out there at this point that works. And so it is an urgent need. Worldwide, there's 15 million people living with spinal cord injury and another 900,000 each year get an injury. While in Australia too, we have great healthcare here. So
Mm.
now with a spinal cord injury, people have a near normal life expectancy. So
Mm.
if you're 18 years old, when you have a rugby accident, you're going to be living with it for another 60 years or so.
Mm.
Whereas with my international development training, I come up with a different viewpoint with our near neighbours in Indonesia. 25,000 people have spinal cord injury a year, but because of their healthcare is not as good as what we have in Australia, their life expectancy, last time I looked, was only a few years. So it could be devastating there. So in addition to making a therapy for our society, we're also very keen on having a therapy that we can deliver
Mm.
to those who are really in need of it around the world.
So, what outcomes are you hoping to achieve from that first human trial, and what would that success look like at that stage? So, what is your first trial? What are you hoping to achieve out of that?
The first trial, at a minimum, we don't want to have any adverse effects
Okay,
because we're going to be targeting people with chronic spinal cord injury, so at
I
least
was going to
12
ask
months
that.
after injury in the first stage. As we progress through the trial, we'll bring that time frame a little bit earlier after injury. But the reason we've chosen 12 months to start with is because we don't want to make someone's injury worse. We do know in our preclinical research that this therapy would be very good for someone with acute spinal cord injury.
Mhm.
But as I said before, because clinicians cannot predict an outcome for a person, we
Mm.
could potentially interfere with that outcome and make it worse for that person. So we're going to start with chronic spinal cord injuries. And we do think that, the therapy would work for chronic spinal cord injuries,
Mhm.
but there's going to be more scarring. There's going to be more sort of degradation of pathways over time. So it might be a harder ask. We don't think it's not possible though. There's evidence that says that it can be done. So we're going with that. But it's going to be more difficult. So from our point of view, we may not see, signs of efficacy at this point because injuries are too old. So as long as we don't see anything going wrong, we can then in future go towards earlier and earlier injuries to find those that do respond.
And of course, this is a world first, this clinical trial, isn't it?
Yes. Well, certainly this nerve bridge transplantation is
Yeah.
the critical aspect to it. And we do think that not just for ourselves, but this nerve bridge technology that we have developed here on the Gold Coast is going to be very useful for other cell transplantation therapies. I mean, we are already thinking about how can we apply it to brain injuries as well in
I was going
different
to
ways.
ask you. I was going to
Yeah.
ask you that progression, the long-term vision on it.
Yeah. So because of our understanding of discovery biology, we know that these cells, as I said before, can produce all these growth factors, exosomes, little small particles that can be secreted from a cell and communicates with other cells. We can take those cell products too and then apply them to brain injury or different times after injury. So we're looking at that as well now.
So, can I take you back to the clinical trials, and you're saying you're going to treat the long-term spinal injured patients. When you're talking long-term, what timeline are you looking at on the long-term
So
for
yeah, so
clinical trials?
again, we're taking a very open approach that when I started my career, it was impossible to repair the spinal cord.
Mm.
And we thought we might find some interesting things along the way. Then it changed to, well, we might be able to repair it. And then became evidence that you can repair it in some circumstances, but it's not good enough yet. So now we're thinking it is possible to repair the spinal cord injury.
Right.
And so therefore, there's no upper limit. We are looking for people with any age
Okay.
injury.
Yep.
Why say we can't do it at 50 years after injury? We might be able to. If we don't look, we certainly won't know. That's, again, another sort of innovation in our trial. The other trials want to have everyone to have the same injury.
Yeah.
so they can reduce the variation. We want diversity of injuries, high and low injuries, time after injury, severity of injury, so that we can look for those injuries that respond versus those that don't respond. The other trials that pick one single type of injury, they might be picking the injuries that don't respond. So they don't get the outcomes that they want. Or maybe they do respond, but they're not applicable to other types of injuries or other levels of injuries. Another great innovation for our trial is that we want at least 40% women on the trial.
Okay.
And the reason is people say, oh, yeah, some advisors have said, but women only count for 20% of the spinal cord injury population. Well, when we do the maths on it, if we have 20 people having cell transplantation and only 20% are females, then that means that we're only going to have 4 women on the trial.
Yep.
If we only have a 20% success rate in detecting efficacy, we might pick those 4 women who don't respond. Then we don't know, is it not responding because they're not responding, or is it because there's differences between in the female biology, which we know there are. Women have hormone changes and immune responses that are different. Maybe they will respond differently to the cell transplantation than males will. So we are deliberately having at least 40% women. So we get at least 8 women, possibly more, on the trial. That way we're more likely to see whether women respond, because we want this therapy to be suitable for women and men equally.
How many people in the first trial?
We want a total of 30 people recruited. 20 will be for the cell transplantation, and then there'll be 10 people in a control group. The control group will do just the long-term rehab. Unfortunately, in Australia, people with spinal cord injury don't do long-term intensive rehab. When they get discharged from hospital, they might get an NDIS package if they're under 65. Otherwise, and they do what they want with that package. They might get some rehab, or they might not. They might do 3 months of rehab or 6 months, but we don't hear of people really doing 3 hours a day, 5 days a week for a year rehab. So we need to have that comparison data between the controls and the treated people. And we asked our community about that. How do we do a control arm? Because a lot of people do want to have the cells, but some people don't. Some people are happy to participate in the trial for the benefit of the greater good, which is fantastic. But other people said, well, I get a year free of rehab. So it's, why not? You get a benefit out of it no matter what. So they're there. It's a great community there. And so hopefully we can get that, recruitment happening in a way that, keeps everyone happy. But it is a trial with a control arm. So it's going to be tricky in that sense.
So the Clem Jones Centre, or the Clem Jones Foundation, has been a huge supporter, hasn't it? And how important has philanthropic funding been to your progress? And let's talk about that vital arm that allows these sort of this sort of research to take place.
Yes, philanthropic funding is absolutely critical for success, and the Clem Jones Foundation was a lifesaver for me. In 2015, I'd been a contract researcher, so having short-term contracts all of my career, ever since 1996 it was. And my job was running out end of the year. My wife had just been offered a job in Sweden, and Clem Jones Foundation, we had pitched to the Clem Jones Foundation that we can create a cell transplantation therapy for spinal cord injury. And they came back and said, okay, we'll back that idea, but on the condition that you translate it and you leverage the funding.
Okay.
And so my wife and I decided, okay, we'll stay here on the Gold Coast. Well, I was in Brisbane at the time, actually, and we moved to the Gold Coast later on. And so without the Clem Jones Foundation, I'd probably be in Sweden doing something else. Probably having a nice lifestyle over there, I'm sure, but completely different. We wouldn't have this therapy here. But with that carrot and stick approach, I've translated and here's some money, but you have to go and leverage it. I have absolutely embraced that, and always with the foundation brand and their networks too. We've gone out to the community and we've shared the story. The Perry Cross Spinal Research Foundation here on the Gold Coast has been brilliant supporters, long-term
Oh,
supporters too,
yep.
and raised the awareness,
Mm-hmm.
brought in the community. So we have lab tours every week at almost once every 2 or 3 weeks. We have a lab tour where the Pericross Spinal Research Foundation brings in people to see our lab firsthand. That can be just a person who's got spinal cord injury or their family or friends, some philanthropists, politicians we've had coming through to see the research. And that's been great because they ask us questions,
Mm,
uh, explain the impact to them, and allows us to better design our trial and design our research in a way that will suit them much better. But that's all because of philanthropy and that sort of culture we're creating of donations. And it can be a small donation, it can be a very large donation.
mm,
But then with donations and the community support, we can then go to government
mm,
and get the funding. We got the recent Medical Research Future Fund stem cell mission grant of $6.8 million for the trial
mm-hmm.
to support the trial because we had over $5.5 million of philanthropy
Yep,
already secured for the trial. So it's an easy ask for the government then to say, well, we've got good community buy-in for this one.
absolutely.
Therefore, the government, while it's putting in a huge amount of money too,
Mm.
it's all about risk management too. And, it all comes into
Oh,
that of,
absolutely.
there's buy-in from multiple parties. And, the co-design of our therapy with the community has been critical for our success. We
Yeah.
want to make sure it's right. So philanthropy is exciting. It's
Mm,
brilliant. And we get to talk to so many people, great business people and lawyers and, the politicians. They're all sort of in our network because of philanthropy driving
mm,
this push
mm.
of translation. And without government grants are fantastic, but they're very competitive.
Yeah, they
You
are.
might have a great idea, but just
Yep,
for whatever reasons you don't get the funding.
yep.
Philanthropy allows you to get the work going,
Mm, mm,
start you on that
mm.
track, and then
And
you just have to snowball it.
that whole community buy-in, the whole community, like to have something of this ilk on the Gold Coast is just phenomenal. I mean, that we have, the studies and even beyond spinal cord injury, the centre is also tackling neurodegeneration. I mean, can you tell us about your research in Alzheimer's disease and particularly around that smell clinic?
Yeah. Oh, yeah, right. A couple of points here. It's all
Yeah.
great. I mean, Gold Coast is fantastic. I've got, teenage kids here on the Gold Coast, and they say to me, "Oh, yeah, when we go to university, where should we go?" I say, Griffith University here on the Gold Coast has not just world-class research, but world-leading research. We have everything we need to do right here. The clinicians here on the Gold Coast are brilliant
Oh,
risk takers who want to make a real difference to their patient population. And also on the Gold Coast, we have a lot of elderly people here. With as we all know, we have that sort of fear or hope that we don't get neurodegeneration.
mm, mm.
Well, so we also in our spare time looking at neurodegeneration, and again it comes around the sense of smell.
Yeah.
So we in Alzheimer's disease, we all know that the signs can be cognitive impairment. You forget where you put your keys to start with. And it's difficult because when are you too busy that you can't remember things versus you have a
Mm,
problem remembering things?
mm,
And, neurodegeneration is not a normal healthy part of aging. Many people do not get neurodegeneration. Neurodegeneration and cognitive impairment is a disease that happens to some people, unfortunately. Problem is that when your kids tell you, mum and dad, maybe you should go and see your GP about your memory loss, it's already too late.
mm.
We're already on that path to memory loss.
Mhm.
What we now know is that almost every patient who has Alzheimer's disease, nothing's 100% in biology, so let's not say it's 100%, but almost every patient will have a reduced sense of smell. And the evidence is gathering that the sense of smell will be reduced maybe 20 years before before you get signs of cognitive impairment, before you start losing your memory. So that tells us that something's going on inside the nose. That might be a symptom or a trigger for the onset of Alzheimer's disease. The real difficulty with neurodegeneration is it's a slow, progressive disease. So when the patient goes to a clinician at the age of 65 or 70, those symptoms have already started a long, long time before. And so there's a limited tools that the clinicians can use. And they say to us, if we can just treat the patients earlier, we'll get better outcomes. There are some drugs becoming available for Alzheimer's disease, but the problem is they're applied too late. Apply them earlier and earlier, we'll get better outcomes. We might stop people getting that progression to mild cognitive impairment in the first place. I mean, it's our hope. So what's going on in the sense of smell?
Yeah.
Well, I went to a conference for ears, nose, and throat clinicians, and one person came up to me after our presentation and said that he lost his sense of smell 20 years ago. He works in the field, but he didn't think, of that link between sense of smell and neurodegeneration. And he said, 20 years ago, I lost my sense of smell, and then last year I was diagnosed with Parkinson's disease, another neurodegeneration disease, in which people also lose their sense of smell. He said, if only I had known, something could have been done. What's happening in our sense of smell? We're breathing in air and we're breathing in bacteria and viruses, as I said before. And they go very quickly from some bacteria and viruses go very quickly up into our brains. We know again with COVID, some people can get terrible long-term impairments, long COVID, and other viruses do too. Our brains are in some ways just incubators for bacteria and viruses.
Not sounding good.
Don't understand what goes on in there when they're there. And while it might be genetic background, it might be environmental factors as well. Exercise and diet has an impact. But for some people, that combination can lead to neurodegeneration. So we need to find out. And so we are proposing here, we have started a smell clinic here on the Gold Coast where we are testing people's sense of smell. And if you're in the lower range of it, say in your 40s, then you might be on that path to neurodegeneration. So therefore we can then track you, treat you before we might get to that point. It's difficult because someone at 40 cannot be diagnosed with late onset Alzheimer's disease by definition, but also they don't have all the other symptoms that go with it. So it's a complex task that we have, but we're starting now to do that. We're working with great clinicians here on the Gold Coast. Michael Leahy, in particular, at Healthy Minds Clinic here in Southport is really, top-notch, enthusiastic clinician who wants to have that sort of holistic view of a person's lifetime to see how we can stop it. That's what is so good about the Gold Coast is that we've got brilliant people here working with us to make this happen.
Can anyone go to the smell clinic?
Yeah, we're wanting all ages. In fact, we've got a trial at the moment where we're clinical research where we're looking for healthy people and people with impairment at all ages to anyone over 18 years old. So we can compare people with loss of sense of smell with those who might have also signs of cognitive impairment. And I should say there's many good reasons why someone might have a poor sense of smell. Many people have the wrong sort of anatomy of the nose or hay fever. That's not going to be related to neurodegeneration. But we need to find those sort of links and rule out those ones that have a known cause versus those who don't have a known cause. Because what we think is that bacteria can destroy the olfactory nerve, reduces functioning, like happens in COVID. And I should say too, right now, there's this big outbreak of melioidosis in northern Queensland, which is a bacterial infection. And because of all the wet weather up north, a lot of people are getting this bacterial infection that's normally in the soil. And it can get into your body, can cause sepsis in the blood, but also can get into the brain. And our research has shown that it can go from the nose into the brain and then spinal cord within 48 hours. And it can stay there for a long time, and it can cause micro levels of damage, which can spread as well. So we know that this bacteria can get into our brain quickly, and some of those ones are quite nasty.
Sounds, yes. Sooner we get the trials going, the better for all of us, by the sound of it.
That's right, yeah.
So finally, what does success look like for you? But just not in the trial, but in the legacy of this research.
Success for me is that we contribute to building a community of innovation, particularly here on the Gold Coast. For me, science is not just doing the biology or the physics or the chemistry, and that's what we get taught at schools, which is great. It's the foundations. But what I love about science is the creativity and the imagination. And so when we recruit people to our team, we recruit diverse opinions, just like me, agricultural background. We're not looking for someone who's an expert in what we already do. We want new opinions. Yeah. Some people think I might be a smart person, but I haven't got a therapy in the clinic yet that repairs spinal cord injury. So that 15-year-old is, doing great. Might not be brilliant at school in the schoolwork, but they've got a creative mind. They might be the one who's got that imagination that gives us a break that makes our therapy work. And so when we recruit people, we want people who are smart, but we also want people who are creative. And they might be good at engineering, for example, or they might be good at, we worked with, to make a film for, we made a video of our, an animation of our therapy that we can give to show the community. And we worked with a film school. And so we were working with people who had no idea about biology, but we had to explain to them, and they came up with an incredibly good video that we can use. So we want people who are artistic to work with us as well. And that's what I want. Our kids are here on the Gold Coast, but I want them to say, wow, I could be working in world-class research here on the Gold Coast, and I'm not the smartest person in physics or chemistry or biology, but I can do it because I'm really good at writing, and we need people who can write. Or I'm really good at the legal aspects of it because we need lawyers to talk to all our investors and things like that. So that's what we want. There's so many ways in which our kids in schools can be contributing to us. If we can embrace that and promote that, and we can do it here on the Gold Coast and elsewhere in Australia, we're winning. And if we can just use our therapy as an example of how it can be done, that would be a great legacy.
Look, it's been an absolute pleasure talking with you, James, and I'm absolutely blown away by what's happening here on the Gold Coast and the amount of innovation, world firsts, and you're leading a charge on something that's exciting, and I can't wait to hear more about it. But for some of the things you mentioned, the smell clinic, some of the other things I'll make sure that we put a link to as well for everyone. But thank you very much for speaking with me today. I can't wait to speak with you again in 12 months or 2 years after as the trail continues.
Great, my pleasure. Thanks for having me.
Thank you. Thanks for listening today. For a complete list of podcast episodes and transcripts, go to rdagoldcoast.org.au/podcasts. And don't forget to follow us on Facebook, LinkedIn, or Twitter.